The treatment landscape of MS, of course, has evolved dramatically, especially over the last few years, and there are many more choices at the disposal, the armamentarium of providers and patients to consider. We've done, I think, as a community, a pretty remarkable job in achieving a very different view of MS. The new MS, as I might refer to it, someone newly diagnosed with MS has a very, very different prospect, we believe, long-term, as compared to someone diagnosed even 5, certainly 10 or 20 years ago. And that's because early administration of therapies that can modify and limit injury are associated with improved outcomes. And we have a lot of data to say that delaying treatment with effective therapies results in injury that we cannot really catch up on. And while we have improved the ability to limit injury, we're not yet where we would like to be in terms of fixing things that are already injured. So there's an imperative as the field now is generating a consensus to consider early treatment and early treatment with effective therapies, of course, always balancing risk benefit in individual patients. And the bar is set up considerably higher than it had been in the past. We're no longer accepting in general that people will have one attack a year because it's less than average. We would like each individual patient to have no new focal inflammatory disease activity, meaning to essentially abrogate the relapsing biology. And we can achieve that now with medications that are generally very well tolerated and, at least for a few years, appear to be quite safe. And that's different historically from the consideration that the more benefit against MS, the more of a risk you need to take in terms of potential complications. So the treatments that we have that are high efficacy are not without potential issues, but we know for the most part what they are, how to monitor, screen, select people, and ensure that they remain safe. We are therefore able to limit new injury quite well from relapsing biology, but great unmet needs remain, including progressive disease biology, where we're beginning to make inroads, and there's a series of new treatments that are targeting central nervous system, compartmentalized inflammation and degeneration, which we think both contribute to the non-relapsing progressive MS, and several new molecular pathways that we think are implicated in those aspects of MS have resulted in both the notion of repurposing existing medications that are out there for other indications, as well as exploring new small molecule targeting therapies that can access the central nervous system. And finally, of course, limiting new injury from both relapsing and progressive disease processes is, of course, one important goal, but the other ultimately will be, if we can, fix things that are broken. And so in MS, as in other fields, there continues to be a great impetus in terms of looking at therapeutics that can fix things that are broken, that can repair and or contribute to a more permissive repair environment within the central nervous system of patients.